So we're going to start. Good afternoon, everyone, and welcome to this UICC Virtual Dialogue on the critical role of evidence-based data in addressing antimicrobial resistance, or AMR, for better cancer treatment and care. I'm Shalini Jaishekhar-Ziur, and I'll be your chair for this session. So there were 20 million new cases of cancer reported in 2022, and these numbers are only set to increase. Scaling up cancer control efforts will be in vain if appropriate measures to address infections, especially drug-resistant infections, are not implemented. Infections are the second leading cause of death, for people living with cancer after the cancer itself. And many antimicrobials like antibiotics or antifungals are vital for routine surgery and treatments like chemotherapy and radiotherapy. The emergence of drug-resistant pathogens is seriously affecting cancer care treatment and outcomes. If we don't act now, all the progress made in cancer care will be undermined. So the 2024 Political Declaration on AMR contains several calls to action which the NCD community is perfectly placed to take a lead on in the coming years, and progress in these areas will have a positive impact on cancer care outcomes. And we're really pleased to see that that AMR is already included in the draft political declaration on NCDs and mental health with specific reference to cancer. And we must ensure that this UN high-level meeting and others on health continue to include action on AMR in them. So in this regard, the objective of today's event is to highlight the findings of recently published studies on how AMR has a negative impact on cancer treatments and care, and to also emphasize the vital role of the NCD community in advocating for action against AMR. Our first speaker is Antonella Cardone, who is the CEO of Cancer Patients Europe. Antonella has over 25 years of experience in working in social and health issues at the international level, and has also been leading the work on AMR at Cancer Patients Europe. Antonella will share insights on how AMR affects cancer care, highlighting the experiences from a patient's perspective. It's over to you, Antonella.
Thank you, Shalini. Maybe you can start sharing my slides. Okay, thank
you. Can you see them?
Yes, they're there. So thank you, Shalini and the UICC for introducing such a relevant topic. I am glad to be given the opportunity to bring the cancer patient voice to this panel on such a pressing issue as antimicrobial resistance. Next slide and next slide. You can go to the next one. Yeah.
Can you see it, Antonella? It's all okay?
Yes.
Yeah.
So when we talk about cancer care, we often think of advanced therapies, access to innovation and precision oncology. But there is an invisible threat that we cannot ignore. 50% of cancer deaths are due to an infection. Cancer patients are 3 times more likely to die from a fatal infection compared with patients without cancer. And yet, AMR is rarely registered on death certificates of cancer patients. And most cancer treatments, like chemotherapy, radiotherapy, stem cell and bone marrow transplants, weaken the immune system. And this makes these patients highly vulnerable to infections. And the AMR infections are a threat to the progress made in innovative cancer treatment. And AMR may make some cancer treatments unviable by 2030. In a poll of 100 UK oncologists, 46%, so almost 50% of them, were worried that chemotherapy will soon become non-viable due to AMR. In addition, AMR not only threatens survival, but also undermines quality of life, causing social isolation for the fear, just for the fear to get an infection, and causing huge economic burdens on the patients, its family, and the healthcare system. The cost implication of AMR is very high and is higher than the cost of targeted antibiotic treatment. So what is the point of delivering an innovative treatment that may cost millions if then the patient dies because of a stupid infection? Slide 2, please. With these numbers, at Cancer Patients Europe, we cannot ignore this issue. We need to safeguard cancer therapies from the AMR crisis. We need to generate political will and influence policymakers. We need to build and present a unified voice between patients, healthcare providers, and researchers. We need to secure political commitment and momentum through sustained advocacy. A patient-led white paper with a call to action or a manifesto could help, on which the endorsement of MEPs, members of the European Parliament, could be asked. We need to raise awareness on the severity of AMR, positioning it as a health crisis that could set back many medical advances, particularly in vulnerable populations. We need to find the right hook. So emphasizing patient-centered solutions as they are key driving points in cancer advocacy needs also to be taken into consideration. Also leveraging public awareness and education campaigns. Develop an AMR ecosystem from prevention to surveillance to further research and right policy in place, and promote collaboration across national boundaries. And this is part of our essence, of CPE's essence. So cancer advocacy efforts in Europe have benefited from a transnational approach through initiatives like Europe's Beating Cancer Plan. Next slide, please. So, next, I don't see next. But
Oh dear. Do you see it now, Antonella?
I don't, but if the others see that, that's fine. Because, I mean, so this is why at Cancer Patients Europe, we believe that there should be a clear and well-structured AMR strategy at the EU level. A coordinated approach that links research, funding, and public health interventions, starting with prevention of infections through using the right tools and behaviors, educating healthcare professionals and the citizens through a One Health approach that is at the intersection of human, animal, and environmental health, avoiding silos. We need to discover more antibiotics, so research and development is vital. We need to incentivize research and development. And the introduction of a transparency and exclusivity voucher with a one-year extension of the patent in the pharmaceutical strategy might help. But with AMR, there is also another problem. Yes, we need more antibiotics, but also we need to make the already existing antibiotics accessible. Of the novel 18 antibiotics developed since 2010, only 2 are available in all the 14 high-income countries. So there is a growing need to tackle the restricted access to new antibiotics, as evidenced by the fact that only a small fraction of recently launched antimicrobials is widely available across high-income countries. So in this scenario, we believe that a solution lays in the establishment of a new wide system to incentivize the development of needed antimicrobials and ensure fair and equal patient access. An AMR categorization should be created something similar to the orphan designation that exists for rare diseases, to highlight and prioritize antimicrobials that require support. And this categorization could be introduced during the ongoing revision of the EU pharma legislation, drawing lessons from the successful implementation of the regulations for the orphan medical products. Then while the revision of the current EU pharma legislation offers an opportunity, it also presents challenges for addressing AMR in a comprehensive way. The inclusion of a development incentive is also a positive step for R&D, but it's not sufficient to guarantee patient access. So we believe that a pan-European subscription model would represent a good solution for us, as it would reduce inequalities in access to antimicrobials across Europe. Its success, however, depends on the commitment of all EU member states and the establishment of an appropriate incentive that reflects the EU's role in a global solution. Otherwise, member states should implement individual access incentives to prioritize on antimicrobials. And this is, for instance, already happening in some cases, like the subscription model in the UK, or the premium price in Germany, or revenue guarantees as it was piloted by the HERA. And I stop here for now, and then I'm open for questions. Thank you.
Thank you so much, Antonella. And I just forgot to mention to everyone that we'll hear all of our speakers, and then we'll go to a Q&A session towards the end. Thanks. So our second speaker is Diane Flayhart. Diane is Director of Global Public Health Antimicrobial Resistance at BD. She drives global policy and advocacy efforts to improve diagnostics and antibiotic stewardship through global public health initiatives, and also leads efforts for the Antimicrobial Resistance Fighters Coalition. Diane, could you share insights from the recently published findings of the Cancer and AMR Consortium studies on how AMR is adversely affecting cancer treatment outcomes? It's over to you.
Great, thank you, Shalini. And thank you to UICC for hosting this important discussion. So this afternoon, I'm going to share some recently published data on the impact of AMR to cancer patients. Next slide. And stepping back to say, so why did we decide to do this research? I think there's been a lot of good data talking about the impact of infections and infectious diseases to cancer patients. So in that bottom left-hand corner, you can see some publications that highlight that mortality rate is significantly higher for cancer patients with sepsis in the ICU. That there is a higher risk of getting an infection-related death in the cancer population versus the non-cancer cancer population over 2.9 times. So there was some data that we understood that cancer patients were getting more infections. We also heard op-eds. So if you look at the upper left-hand corner, you can see an op-ed from Dr. Sears, who talked about is not just the tumors that are responsible for cancer patients who die, but is actually the superbugs that are sickening those patients. So this sort of call to action we saw. In the upper right-hand corner, you can see another publication which clearly called that there was a lack of data in the etiology of infections, specifically in oncology patients in the US. So based on these calls for action, we worked together with UICC and AMR Action Fund to bring together what we call the Cancer and AMR Consortium, with the goal to better understand the impact specifically of AMR, of drug-resistant infections, on cancer patients, and to do that to accelerate advocacy, policy, and innovation. So next slide. So we published 2 papers, one in December in Cancer Medicine and one last month in the Lancet Oncology. And the first paper looked at inpatients, and the second paper looked at outpatient findings. We wanted to really kind of pull those data sets apart and really understand what the impact was in the hospitals where patients were receiving care. And then since many patients are moved to the outpatient setting for care, what did that look like as well? So for the inpatient study, we looked at over 4.6 million patients, patient records. And then for the outpatients, we looked at 1.6 million isolates. We looked at both gram-negative and gram-positive isolates in the study. And we looked at multiple sources. We thought that was really important because many of the studies that are looking at cancer patients and the burden of a drug-resistant infection, we're looking specifically at blood or urine. So not broadly across all the different sources in which a patient could get an infection. So we look broadly across all source types. Next slide. So when we began to collect this data and analyze it, we wanted to make sure we had a really strong group of scientists to look at the data and understand it. So Dr. Yehuda Marte, who's also a speaker today, is one of the authors on the paper. So we had both oncologists looking at this data as well as infectious disease doctors. We really wanted to make sure that we were looking through the lens of both groups that are managing and caring for these patients in the paper. I don't have time today to go through the whole paper, but I do encourage you to read it because I find the discussion section quite interesting. A lot of great takeaways there. But what the data showed overall is that for inpatients, there's a 1.5 to 2-fold increased risk of getting a drug-resistant infection versus a non-cancer patient. And if you look at the bar graph on the right-hand side, that's all the different organisms we looked at. So we looked at fluoroquinolone non-susceptible gram-negative organisms. We looked at ESBL producers. We looked at multi-drug resistant gram-negative organisms, carbapenem non-susceptible gram-negative organisms. And then for the gram-positives, we looked at meth-resistant Staph aureus and vanc-resistant enterococci. So in those bar graphs, the different colors are representing the different sources. So if you look at the top bar, which is the fluoroquinolone non-susceptible isolates, and the green section, you can see that there were significantly more non-susceptible isolates in the cancer population, the top bar, recovered from blood as compared to the non-cancer population. And really, if you look across the board, you'll see that from a rates of infection, all organisms were statistically higher in recovery other than Acinetobacter as a specific individual gram-negative organism. But for all gram-negatives together, every source had higher rates of resistance. Next slide. So then we wanted to say, what does it look like in the outpatient setting? We know that we're moving patients out of the hospital to receive care in a different environment, but we were quite surprised to find that the rates of drug-resistant infections in isolates from outpatients was even higher in the outpatient setting. So 1.2 to 5 times higher across key pathogens from different sources in cancer patients. And on the right-hand side, you can see the visual abstract that was published by the Lancet Oncology. And in the visual abstract, there's a small graph there that you can see where it's showing that the rates of resistance for all isolates were significantly higher. What was really compelling about this data was, for those of you that are microbiologists on the phone, both the rates of resistance was significantly higher, as well as the percent non-susceptible. So whether you're looking at an antibiogram that was being built in the lab, or looking at rates of infection overall within your oncology unit, both were significantly higher. If you click one more, you should see a
Did it
little
work?
one more. Yep, maybe one
Did it
more.
work time? One more. There you go.
Oh, there we go. Perfect. So here you can see, and I know it's pretty teeny, but this is actually all those sources, so that the top area is all sources combined. And then you can see we've broken it down by urine, skin, respiratory, blood, and other. And those dots, if they're to the right-hand side of that vertical line, that means there's more isolates seen across all those different sources, across all those different organisms. So the only one that didn't have statistical significance was MRSA from skin, which is that one dot on the left-hand side. So this data is quite compelling and really makes us question if we're seeing these rates of drug resistance, should we be doing different guidelines, different clinical pathways to manage patients? Next slide. These are two other studies that were published recently. One looked at cancer patients and length of stay. So here you can see that patients, whether those solid tumor patients, myeloproliferative cancer patients, or transplant patients, that the length of stay was higher for those patients that had cancer and also had a hospital-acquired bacteremia event. And then on the right-hand side is a scoping study, which I think we'll get into more details later this morning, talking about the prevalence of these pathogens in patients with hematological malignancies. Next slide. So this is my last slide. So in conclusion, I think this data really caused the need for enhanced infection prevention programs, especially in the outpatient setting where we saw such a dramatically high rates of resistance. We have both focused antibiotic and diagnostic stewardship are required, and the increased use of rapid diagnostic tools are also critically important. And we believe that these have implications to clinical practice and guidelines that we can discuss more, implications to global and regional policy. I think Antonella made some really very important comments about how we need to make sure this data is understood and that we can do advocacy and awareness building around the risks and the needs for better access to both diagnostics and antibiotics for our cancer patients. And then probably my last call to action is additional research. So these are great studies, but we need to see more. And so we're looking forward to working with others to bring this data forwards. Thank you. I look forward to questions at the end.
Thank you. Thank you so much, Diane. Our next speaker is Dr. Najy Alsayed. Dr. Alsayed is a global therapeutic area head for infectious diseases at the Menarini Group. And prior to joining pharma, he practiced for several years as a clinician in internal medicine and nephrology, and also as a researcher in cardiovascular and lipid metabolism in Paris, France, and at the NIH in the US. So Dr. Alsayed, can we do more to combat AMR in heavily immunocompromised patients? Please tell us more about your study findings. It's over to you.
Thank you very much, Shalini, for the introduction, and thank you for UICC for the invitation to talk about this critical topic. Good morning and good afternoon, everyone. So if we can go to the next slide, please, Shalini. I just want to very briefly put AMR in its larger scheme of devastating impact. And as you can see, we are mostly familiar probably with the two numbers of 1.27 and 4.9 million of deaths that were published in the Lancet. But in the WHO paper, they also showed that there is a huge actually social impact, as you can see, with a 28 million actually people living in poverty projected by 2050. And there are, of course, an increase in the healthcare provisions and spending if we do not act now decisively. Next slide, please. And this is an important slide, I think, showing that if we don't act decisively today, the number of these death cases related to AMR could actually raise up to 10 million. And this is, of course, something that we definitively need to work on. But interestingly, as you can see, even when you are looking at how much of spending to support combating AMR within the remit of other infectious diseases, you can see that there is almost 1/4 despite these hugely clinical impact of AMR. And also on the upper right side of the slide, you can see the economical impact also of AMR on the global scale. Next slide, please. So specifically to the questions now, what can we do? I think first of all, we need to be the most efficient because we have urgency and we have need to act now. And that efficiency actually goes through data that has been published in the Lancet, which shows that 80% actually of the death cases that are related to AMR are attributable to 6 key pathogens. So we need really to focus lots of our work, data generation, research, and novel antibiotic development to tackle these 6 major pathogen in priority. Next one, please. Secondly, is actually, this is also in agreement with what Antonella shared early on and what actually Diane showed. When we look at the data that are describing the impact of AMR on other diseases, as you can see, the green part is where we have the most of the publication. And as you can see, this is at best is moderate with very few so far available publication and a large number of situations and clinical entities where there is no data whatsoever on how AMR impacts these. So while oncology took some timid start, we are now trying to catch up with that in collaboration with a number of actually the key stakeholders in this call and outside. But we definitively need to continue doing that, giving that picture that you can see here. And if we can go to the next slide, please. You can see that the first number, of course, is what have been highlighted by Antonella and Shalini, and so I won't come back to that. But our recent literature review data shows that there is an acceleration and increase in how these multi-drug resistant gram-negative pathogens are impacting oncology patients. And you can see that between 1990 and today, there have been over a four-time increase in this one. And this is not only on the clinical side, but there are also implications to healthcare cost owing at least in part to the extended hospital duration and ICU therapy. And of course, as Antonella mentioned very, very importantly, there is a social impact on these patients and their families, which we often overlook. Last but not least, this kind of impact is not just actually at the global or the regional European level, but even when you dive into the country level, you can see that this is a really same, if not more dramatic picture in some cases with the example of Italy that you can see here on this slide. And I won't go to the details of each one in the interest of time. Next slide, please. In this data, you can see that actually Antonella mentioned the impact on the oncology patients. I won't come back to that, but you can see on the bottom part of the slide that this mortality increase is also present in other immunocompromised patients, which are the solid organ transplanted patients. So clearly, this is very important for most, if not all, of the immunocompromised patients, among which oncology and, of course, transplanted patient. Next slide, please. And of course, again, Antonella talked very nicely about the social impact in the oncology, but you can see that this is, again, similarly felt and lived by the patients that are getting these transplanted patients, some transplanted organs, which is a huge advantage, of course, and as you know, a progress in our modern medicine, but nonetheless, with these AMR-related infections, they are heavily impacting them and socially also. Next slide, please. And of course, I think one important element that Diane kind of briefly touched on, which is the importance of rapid diagnostic testing. We clearly need to have an appropriate empiric therapy, because you can see on this, there is a huge impact on the inappropriate empiric therapy. And to do that properly, we need to work more and develop more these kind of rapid diagnostic testing to allow a much earlier empiric use of these targeted therapy to the pathogen that the patients are suffering from and infected with. Next slide, please. And now this is, of course, a very important element. I just wanted to share briefly with you what is happening when you look at the development and the return on investment that is made in the antibiotic area. And you can see very easily on the left side of the slide that while the cost of development is more or less comparable to all the other diseases, clearly the revenue is much, much smaller. And this is, of course, does not only have an economical impact, it also has a very significant impact of not providing these patients with the benefit of these novel antibiotic to combat the threat of AMR. So if these patients do not access these novel antibiotics, so even the one that we have succeeded to develop and put on the market, they are not allowed to play their full impact to really save these patients' life. And this is a very critical element. And on the second, the right side of the slide, you can have another demonstration of this with data showing that the cumulative resources and revenue that are generated by these novel antibiotics are not even half of what is required to develop an antibiotic, even when you accumulate 10 years of revenue of these novel antibiotics. So clearly, this is a broken model that needs to be fixed, as clearly Antonella mentioned in the beginning, in the interest of oncology patients, but also many other patients, including the transplanted one. Next slide, please. And of course, the immediate translation of this is what you can see on the pipeline. And you can see that, unfortunately, the antibiotic development is going more and more thinner. To the contrary, to luckily the development and more pipeline product in the oncology area, which are going in the absolute right direction, even if we still need more, but at least it's going in the right direction, while the antibiotic are going totally in the wrong direction. And this is also explained or contributed to equally by the lack of investment. And if you can look at the investment that are being brought to the antibiotic as compared to the oncology, you can see the huge difference between the two. So again, in agreement with what Antonella was saying and Diane, we really need to have this AMR threat tackled better and create and fix that problem of the market, so we can boost the pipeline and encourage more absolutely desperately needed investment to come to this area, and more investment and more companies and biotech staying or coming again to this area. Next slide, please. So in summary, we clearly believe that we have to continue our fight with our forces, but not only alone, collectively, as it has been said here in this call. And we definitively need to make sure that the benefit to the healthcare system, to the patients, to our modern medicine are preserved, as it has been said early on also by Antonella. Now, these novel antibiotics, in the name of efficiency and the urgency, we need to really focus this alongside the incentive to the 6 key major antibiotics that are responsible for these 80% of these cases. We certainly need to generate data on AMR threat, but also more research and more data on rapid diagnostic testing to allow a more appropriate use as opposed to restricted use of these novel antibiotics. We need to enhance educational activities, and I think this is one of these forums, but certainly we need to boost that even more, and that goes with generating the data that are needed to boost that activity. And last but not least, as we said, we really need to fix this novel antibiotic broken model to work with all the key players that you can see here. Thank you very much, and happy to take your questions at the end.
Thank you, Dr. Alsayed. Thank you for taking us through the study findings. So our next speaker is Dr. Yehuda Mate. Yehuda is a medical oncologist and an assistant professor of medicine in the Division of Hematology and Oncology at the University of Pennsylvania. She's also adjunct lecturer at the University of Botswana, where she conducts most of her research work related to access to essential medicines for cancer treatment. So Yehuda, could you please talk us through the results of the AMR scoping review and the importance of coming together to address AMR for better cancer care outcomes? It's over to you, Yehuda.
Thank you so much for the introduction. And I will go through, I think some of the work that we're going to do is going to give a bit of a global scope, which I see a lot of questions in the chart already pointing to. Next slide, please. So this was a study that was commissioned by the UICC Task Force for AMR, and I have to really commend the UICC for being a leader in bringing AMR to the forefront in cancer patients. It was a scoping review that was led by Dr. Danielle Rodin, who is a radiation oncologist. Next slide. So I'll just keep this brief because we've heard a lot about the background on AMR, but I just wanted to emphasize that this scoping review was specifically to look at hematologic malignancies, and so patients who are at the highest risk of infection. And we also wanted to look at bacterial infections because we know most of the burden, the mortality burden, the cost burden is related to bacterial infections in patients with hematologic malignancies. One of the impetus for the study was realizing that a lot of the data generated so far on AMR in cancer patients is from high-income countries. And so we wanted a global landscape of what this looked like in a more sort of general population. Next slide, please. The specific objectives for the study was to estimate the global prevalence of AMR and hematologic malignancies, and then also determine healthcare outcomes associated with antimicrobial resistance. We think that the discussions are usually enriching, and so we summarize some of the challenges and opportunities that were noted in these studies as well. Next slide. So this was a scoping review that involved a huge multidisciplinary team because of the number of papers we started off with. But we wanted to look at all these databases and look at studies that were published focused on hematologic malignancies across different countries from January 2000 to December 2023. As you imagine, there's a very broad definition and range of different cancers that qualify as hematologic malignancies. So our initial yield was 16,000 articles. The titles and abstract were reviewed by a huge team from different countries. We ended up with 974 articles, which had their full text reviewed, and we excluded articles that had mixed populations. And so there were patient populations that focused on solid tumors and hematologic malignancies. To present a more homogeneous assessment, we looked at papers that only had at least 90% of the patient populations included with hematologic malignancies. I will present the results of the 274 studies included. Next slide, please. So we showed that the 274 articles came from 52 different countries. However, there was huge variations in terms of where these articles were coming from. So on the top image, it shows the distribution with sort of blue and dark blues, showing regions that had more papers published on AMR. I think what is striking here is that there were no studies published from sub-Saharan Africa. In summary, 61% of the articles were from high-income countries, less than 1% from low-income countries, and then 14% from lower middle-income countries, highlighting a huge deficit in AMR and cancer papers from low-resource settings. The bottom graph shows the annual sort of changes in trends of number of AMR articles published. I think what is reassuring, though, is that there are a lot more articles being published on AMR over the last 2 decades. A little bit of a blip during COVID, but I think in general, an increase in trend. Next slide, please. Our first aim was to look at the prevalence of AMR infections. We focused specifically on what the WHO classifies as high priority pathogens. So these are pathogens where resistance is increasing, but there are very few medicines in the pipeline to address them. And so the top here summarizes the median and interquartile range for these pathogens. I think what I want to highlight here is that most of the common infection types that were focused on in the articles were bloodstream infections. And so this is data from bloodstream infections. We heard from Diane's data that, there are other sources of infections that have really high AMR as well. The top AMR pathogens were third-generation cephalosporin-resistant Enterobacterialis, MRSA, sort of similar to other data that has been published, and vancomycin-resistant organisms. And I think this is pretty striking. It shows that 44% of patients with hematologic malignancies, if they have an infection with these organisms, will have a resistant pathogen. And I think that is pretty significant to think about, especially since these are mostly bloodstream infections. Next slide, please. We also looked at healthcare utilization and disease outcomes. And I think this is where we realized, where we noted that the data pretty thins out. And so fewer studies looked at healthcare utilization and outcomes that we're interested in. And so of the 10 articles that looked at hospital length of stay, AMR does increase the hospital length of stay by 4 days. And that is not insignificant because that is correlated with a huge healthcare cost. Specifically, when they looked at VRE in 4 of these papers, it increased the length of stay from 28 days to 36 days. So that's almost a week. We also looked at papers that had data on mortality. This was very varied. And so we limited it to papers that reported on the hazard ratio. And you can see here that in those 7 papers, having an AMR infection either almost doubles your risk of death to up to 9 times. And so patients who are admitted to the hospital who have an AMR infection are up to 9 times more likely to die from their infection because it's an AMR organism. Next slide, please. So I think some of the key takeaways that we gathered from this study was that there was a high prevalence of AMR there was a high AMR prevalence in high priority pathogens as defined by the WHO. When we looked at healthcare utilization metrics, we also noticed that AMR was significantly associated with length of stay and also mortality. And I think perhaps the sort of biggest takeaway point and a huge call for action is that there are huge disparities in the global representation of AMR studies. And so when we think about low resource settings or sub-Saharan Africa, where there's already a high burden of infection and a high burden of AMR in the population, coupled with lack of access to antibiotics, this is an area actually where there is the most lack of data. And so I think this points to a huge deficit in the data and how we can actually galvanize actions that focus on these areas. Next slide, please. I think some of these recommendations and take-home points have already been highlighted, but I think what this data calls for is like a strengthening of global and AMR monitoring in oncology. I think there are the AMR, the GLASS surveillance by the WHO already addresses AMR in general, but I think realizing that the oncology population is at highest risk of mortality, and severe sequelae from AMR infections. There's a need to not just strengthen global AMR surveillance, but really focus on the oncology populations in these areas. We need to encourage studies in LMICs and actively support these areas. There needs to be interdisciplinary research among cancer providers and infectious disease providers. R&D has been talked about extensively. We need to implement antimicrobial stewardship programs and then also standardize reporting for AMR. We did realize in our study that there was a lot of heterogeneity in how AMR was being measured either at the patient level, the pathogen level. And so I think being able to standardize this gives us a way to actually measure the global burden uniformly and compare rates across different countries. I think this is my last slide. Thank you so much.
Thank you, Yehuda. Thank you to all the speakers for taking us through the findings of the study and also talking about recommendations for next steps that we all together get together as stakeholders and work on. So I'm very happy to open the floor to questions and answers, to a Q&A session, sorry. Maybe I'll start off with Diane. I have a question for you, Diane. So Diane, can you share what some of the reasons are for the increased rates of resistance in cancer patients?
Sure. So some in our paper, some of the discussion we had were why are we seeing these higher rates of infection? And I mean, we all understand that these patients are immunocompromised. However, they're also being exposed to the healthcare system through multiple different visits and interventions. So the combination of receiving medications that can make them more susceptible to colonization, and then having those interactions with the healthcare system, we think that is part of the reason why, even in the outpatient setting, when these patients haven't been in the hospital for quite a while, they still are carriers of these resistant organisms and have a higher risk due to their the medications that they're receiving. One of the most compelling things that we were thinking about is with our fluoroquinolone resistance. The rates of fluoroquinolone resistance in the outpatient setting for some of the organisms are well over 40%. So if IDSA guidelines say that you shouldn't use, an antibiotic when the rates of resistance are over 25%, it's a prophylactic antibiotic, yet we all use fluoroquinolones, and our data shows you shouldn't. I think there's some questions to be answered and some ways that we need to think about how do we use different antibiotics and how do we continue to build our pipeline of new antibiotics so we have other oral options for these patients.
Thank you, Diane. And there is, Maribel, this question was in the chat. Yeah, so there is a question on the chat. I think I'll direct this one to Yehuda. You alluded to it in your presentation, Yehuda, if you could perhaps expand. Do you think that the lack of data from LMICs could be due to a database bias?
Yeah, I think it's sort of multi-pronged. I think there is, in order to be able to really track antimicrobial resistance very effectively, we do need really good data collection systems. But I think the data is being fed by data from laboratories. And so you do need the diagnostic capacity, the infrastructure in the first place. So as much as it is a lack of data, it's not because the data is available but not being fed into a system. I think it points to the fundamental need of an infrastructure for actually being able to diagnose infections, measure resistance to different infections across the general population, but specifically among cancer patients. And so I think it highlights a deficit of a well-built infrastructure, diagnostic capacity, and personnel in these resource settings. And I think coupled with that is really good data collection systems as well to be able to present this data and analyze it.
Yeah, agree. Thank you, Yehuda. Dr. Alsayed, I have a question for you. Can you share a few details on what you want to see next with this data? What are the next steps for your paper?
Yeah, absolutely. Thank you very much. So clearly, one side is to go to the publication and have this information available to the largest number of users. But the second one is actually to have a gap analysis of what data are still missing and what do we need to do in prioritizing the activities and the research data and generating newer one as we go down the road.
Thank you. There's another question, Maribeth. There is another question. I can't find it, Maribeth. Okay, while I'm looking for it, I have a question for you, Antonella. Antonella, where do you see the cancer patients and CPE playing an active role to reduce, if not eliminate, AMR?
So thank you, Shalini, for this question. But I also see that there is this question in the chat, which is
I have it.
interlinked to what I would like to say. Because yes, I agree that especially in Europe, at this moment, with Europe's Beating Cancer plan coming to an end, and so the attention towards cancer coming to an end, it becomes very important to find a replacement, so to speak, where we can keep cancer high and possibly AMR higher on the political agenda. And for me, the national cancer plans are a very good tool that we could exploit more. I believe that now we are ready for those second generation, I could say, of national cancer plans, more comprehensive. They could and should include AMR. So they should include the infections from prevention, surveillance, so data collection, because I mean, the problem with data is not only in low and middle income countries. We have a data problem, a collection of data on infections in high income countries as well. For instance, in Europe, I mean, when I mentioned that 50% of cancer deaths are due directly or indirectly to an infection, that doesn't mean that it comes across clearly. Because most of the times hospitals do not register a cancer, a death for an infection of a patient who entered the hospital because of cancer as a death due to an infection. So there is a problem of data there. And I believe that the national cancer plans could play an important role in monitoring, preventing, addressing AMR. And what we will be doing soon is essentially, I mean, we are working with Menarini as well on this study. We are part of the steering committee, and we hope to leverage those data at the political level. So on one side, we need to work on grassroots with patients and continuously raise awareness of the importance and the impact, the terrible impact that AMR has on cancer patients. But on the other side, we need to influence policy. We need to change the current policy to address seriously AMR. And so we hope that we will soon publish a white paper that could be endorsed, as I mentioned also in my presentation. A white paper could be a good tool endorsed by policymakers and with a call to action, with clear indicators, so that policymakers endorsing it are committed to achieve some results.
Sure. Thank you. Thank you, Antonella. And also related to that, okay, Professor Philippe has a question. Oh, would you like to?
Good afternoon to everybody.
Please go ahead.
Thank you so much to all the panelists for very interesting discussions. I'm a professor of medical microbiology, and I work in a clinical emergency hospital, which has also the oncology ward. My question is, me as a laboratory specialist and member in the antimicrobial stewardship committee in the hospital, I'm facing the situation of being beyond the therapeutical resources. Everything is very nice. We can detect resistance. We can, with molecular biology methods, track the etiological agent in 1 hour. But I would like to ask you, which is the treatment for a patient with the multi-resistant strain that also has cancer, because we are facing Acinetobacter, and I see we are from all over the world. I'm from Romania. I see colleagues from Qatar, and I say hello to them. I just returned 3 weeks before from Doha, and I'm happy that you are here. So the question is, which are the therapeutical resources? Because the laboratory methods has extensively improved in terms of time and the possibility of detection. But what can we offer as treatment to the patient? Because my colleagues from the hospital, the clinicians, we have a very good antimicrobial stewardship program. And also my expertise as PhD mentor is on diagnostic stewardship, which means the correct test for the correct patient in the right time. So all these points, antimicrobial stewardship, diagnostic stewardship, and therapeutic approach must lead us to a treatment. And I would like to ask you, what are you doing with the patient with cancer, with multi-drug resistant Acinetobacter strain that is hospitalized in the ICU, and you don't have the possibility to isolate him? He is in a place with 2 or 3 other patients. And another question is, all these patients are going in different hospitals, probably. So they come with their microbial load from different places. So the patient comes in my hospital, and in fact, he has the bacteria from the National Institute of Oncology, but it's me who trace and isolate the bacteria. So I must report as an associated, as an infection associated to the medical care.
Professor Philip, I might just please interrupt you here if that's okay, because we only have 3 minutes left, and happy to continue this conversation later on as well. But you've raised a really important point about the importance of the infectious diseases people and the oncology health workforce to have conversations at the facility level. But I'm going to hand this over to Yehuda to respond, if that's okay, Yehuda?
Yeah, I think that's an important point, and I'm so glad you raised this, because I think it speaks to the urgency of the issue of AMR, but also shows that it has no borders, right? I think there is a range of spectrum in which institutions are dealing with it. So I'm at academic institutions that can isolate patients, that has negative pressure rooms, and so has resources. But I think there's a whole spectrum where you can't really isolate patients. And so I think we're in a phase where we are going to see AMR resistance, not just from other hospitals within the same countries, but we're going to see AMR resistance globally travel from other countries to our countries as well. And we really relied on our infectious disease colleagues in terms of managing antimicrobial resistant organisms. But to your point, patients actually come in not just with one organism, they come in with multiple organisms. And sometimes it means really prolonged antibiotic courses of therapy, because you cannot find that one drug that they would respond to, and patients actually end up sometimes being on long-term antibiotics, which then fuels more resistance. And so I think your point and just sort of your passion for this really highlights the problem that we are running out of choices for a lot of these patients, and we really won't be able to give cancer therapy if we don't deal with this more urgently.
Thank you, Yehuda. Is Dr. Hadi still here? Dr. Hadi, are you here? Because I see you've listed a bunch of questions. It would be great if you just read one of them out, because we have 2 more minutes left. Please go ahead. One of them. Nice to see you.
Thank you so much. So I just have a question about the 2 things. I mean, well, the first question about at the level of policy, at the level of AI, because at the policy level, the question about the National Cancer Control Plan has been answered. The other question, did we ever look into at the policy level into incentive, into I know the data sharing concept between let's say infectious disease centers, oncology. Did we look into incentivize data sharing? I mean, that's I know. I mean, it's because there's a lot of issues of data sharing that I believe that sometimes is if we don't incentive that process, healthcare professionals, they will not put the time and the effort I know they shouldn't, but it's in there up that day to enter this data, to have it as a area to help sharing the data and put it in a proper way.
Can
The other,
yeah,
can I
go ahead.
just the second question quickly? Did we start looking at, with the whole concept of genomic data and AI? Are we start looking to mix looking at the genomic data of the, maybe this is in high income countries developing with the high setting, but also that could help in other countries looking at genomic of the patient and the pathogen and help us and have a better treatment plan. And back to you.
Okay, thank you, Dr. Hadi. I'm going to actually, Dr. Alsayed, would you like to take care of this one? Please go ahead.
Sure, thank you very much. So it's a very critical question, is indeed. I think the first element, as you've mentioned, is to generate additional data, but also make sure that the available data are made at the disposal of various interdisciplinary area at the hospital. The second one is very important, is what you've mentioned about allowing and enhancing these interdisciplinary interactions and exchange of information between oncologists, microbiologists, infectious disease area, and other actually disease area to make sure that this is happening nationally, this is happening regionally, this is happening at the hospital level, which I think will then make the best use of our knowledge and make most efficient, I would say, decision making. Hope that answers your question.
Thank you. Thank you so much. Thank you, speakers. With that, I think we've come to the end of the session. So as you've heard, the data on the topic is alarming, and AMR is not a distant threat. It is present, and it's a growing crisis that directly undermines our ability to deliver safe and effective treatment to cancer patients. And the evidence shared by our speakers really underscores the urgent need for integrated action across the cancer and infectious diseases community, as you've heard all of our speakers mention, and the importance of all of us coming together and addressing this issue urgently. With that, I will end our session today, and thank you all for your participation and commitment. Thank you so much.